All this is Dr. Mobeen Sayed from DrBeen.com. Welcome to one more show. So this study, it's a small, tiny study, but very important study because it shows something that I've been discussing for 1.5 years, and that is there have been studies, and I would show you those as well, that show that SARS-CoV-1, the previous SARS-CoV, 2003 timeframe SARS-CoV, that SARS-CoV had antibody protection continuing for 2 to 3 years. And the T cells were continuing to be, memory T cells were continuing to be operational after 10 years. This study that I'm going to show you, the summary is the following. The summary is, it's a small study in which what they did was they vaccinated healthcare workers with AstraZeneca. And the basic idea is this: if I am infected before, let's say I am actually infected with COVID, and then you give me a vaccine, I will very quickly respond to it. If my previous memory is there, I will quickly respond to it, and I would respond with a greater uh, titers or greater amount of antibody production compared to somebody who was not previously exposed to the pathogen either through the vaccine or by the previous infection. The question is, how long? I got this COVID infection, how long could I be protected? So if you look at, I had always been saying, if you look at SARS-CoV, 2 to 3 years of antibody protection, and then 10 years later, even T cell protection. Today, I'm going to show you this one, which showed 18 years after some healthcare workers who were infected with SARS-CoV-1, and when they were given AstraZeneca now, 18 years after, their antibody titers went up much more than others who were not previously infected with SARS-CoV-1, which demonstrated that for 18 years the memory cells were sitting in their bone marrows and T cells were present in the lymph nodes. And as soon as the antigen appeared again, they attacked. Second thing that it showed was that was SARS-CoV-1. This is SARS-CoV-2, and there is cross reactivity. So today, after 1.5 years, we have gotten the proof for something that I had been reading from books to the cool bean. It was in the books. So let's look at it. Let's look at it. This is a beautiful area. So here is a letter. So they actually call it letter, but it is a small study. It is printed in JAMA today. And I'm going to directly go to the table where they show the results. I can just very quickly show you here, overall 340 participants. So this is a hospital. If you see here, Kaohsiung Chang Gung Memorial Hospital, I believe it is in Taiwan. So they said a nosocomial outbreak, that means within the hospital, outbreak occurred with SARS-CoV-1 in 2003, and some healthcare workers became infected. Now, in the same hospital, the same healthcare workers were given AstraZeneca, and they saw that antibodies were much greater than those who did not have this infection of SARS-CoV-1 before. So that's the basic discussion. So overall, 340 participants, I'm reading here, were included. Among 8 participants, so this is why it is small, 8 participants. Among 8 participants with prior SARS-CoV-1 infection, 6 women received 1 dose. So among 8, 6 were receiving 1 dose and 1 received 2 doses. Of 332 participants without infection, SARS-CoV-1 infection, 244 women, remaining men, received 1 dose and 37 received 2 doses. That's just the doses. And there is a difference, 1 dose versus 2 dose. Even people who were previously SARS-CoV-1 infected, they responded to even 1 dose with better response. The things that they are writing in this little area here, what they're saying is that, of course, people who were in healthcare workers in 2003 and got infected, and they are still working in the hospital, and there are more healthcare workers, the previous ones are a little older. So now we are comparing two cohorts, one who was exposed 18 years ago and they are older. Second, to this cohort, this 18 years ago, 8 people, their antibody levels were measured after 59 days. So one, they were older. Secondly, their antibody levels were measured a little later, compared to those who just got the vaccine and have not had previous infection with SARS-CoV-1, who were younger and had a shorter duration between the 2 doses. Even then, you would expect that in the older individuals, antibody response will be less. Even then, look at the response. See this, 4441.2 is the units per milliliter, or geometric mean unit, or antibody titer in those who were previously exposed to SARS-CoV-1, versus those who were not exposed to SARS-CoV-1 and were given AstraZeneca. Look at their number, 517.4. And look at the range as well. In this older individuals group, 8 people, previously exposed to SARS-CoV-1, given AstraZeneca now, the antibody titers range was 2337.8 to 8437. And younger individuals not previously exposed to SARS-CoV-1, given AstraZeneca or vaccine, their response was 338 to 699 total range. Again, it is protective. It's not that they did not develop protection, but previous SARS-CoV-1 helped. What a beautiful outcome. This is it. This is the discussion. And I now want to show you some studies related to this. The outcome is the following. The outcome is, if SARS-CoV-1 can give you protection after 18 years, then imagine SARS-CoV-2, how long would it do that? There is a study that I'll show you that says it may not have as long a protection as other SARS or other coronaviruses, but still it is possible from months to 5 years. So let's look at these studies very quickly. I just showed you one that is the latest. Here is another. This study says so this is the durability of immunity against reinfection by SARS-CoV-2. So how long? Although with the Omicron, this reinfection has become more common, but still, what do they think will happen? Reinfection by SARS-CoV-2 under endemic conditions. Endemic meaning just now it is part of, just like flu or common cold, it's part of the societies now. Would likely occur between 3 months and 5.1 years. So that's a very broad range because they just have data that way. This protection is less than half the duration revealed for the endemic coronavirus circulating among human coronaviruses. So they're saying human coronaviruses are known to have 10 years protection, but here this would be about 5 years. So that is one conjecture. Now I'm going to go to this one. This is a study for SARS-CoV, not SARS-CoV-2, SARS-CoV, severe acute respiratory syndrome. This study is in 2007. And look at this. Among 176 patients who had severe acute respiratory syndrome, SARS-specific antibodies were maintained for an average of 2 years, and significant reduction of immunoglobulin G positive percentage and titers occurred in the 3rd year. So greater than 3 years protection. We just saw in the previous talk that previous infection is offering the most robust protection, even more than the vaccines. Of course, there is a risk of dying with that as well, so it's not recommended to go get infection. But the ones who have become accidentally infected and have recovered, who didn't die, their protection is really good. Look at this one. SARS-CoV-2 specific T cell immunity in cases of COVID-19 and SARS and uninfected controls. So here, long-lasting memory T cells that are reactive to the N proteins of SARS-CoV. N protein is the protein inside, right? We talked about that yesterday or Saturday. 17 years after the outbreak of SARS-CoV in 2003. That's the one I just showed you. These T cells displayed robust cross-reactivity to the N protein of SARS-CoV-2. So previous infections, I had done a study a few weeks ago where we discussed human coronavirus or common cold. If someone has a recent common cold, their COVID infection is less severe. That is cross-reactivity. Here we are seeing SARS-CoV 17 years ago infection is offering protection. Then look at this one. T cell immunity of SARS-CoV, implication for vaccine development against MERS-CoV. So again, they are showing that there is a cross-reactivity. So the today's letter that I just read to you, this one, in this letter, what they're saying is immunological memory is the key point to gaining insight into the likelihood of durability of protective immunity against SARS-CoV-2. And then what they say here is, we offer a potential proof of concept for a novel vaccine that targets SARS-CoV-1 and SARS-CoV-2 spike glycoproteins to establish durable protective immunity against SARS-CoV-2 and even other sarbecoviruses. So their conclusion is not to say, hey, previous infection is protective or this infection will be protective. They're simply saying that, hey, if this can happen, that there is a cross protection, then why not make vaccines with the both spike proteins, and that provides a very long duration of protection. So of course they say that limitation is a small data set. We just saw a CDC study of millions of people, and here is a study of 8 people versus 300 people. So it's a small data size, but it's a very important outcome. And this outcome is already seen in the previous studies of SARS-CoV-1. So now this is it, we're done. So just for my drawing's sake, we know that when an infection occurs, so let's say somebody gets infected, this is SARS-CoV-2, right? So that arrives and lands in a person's mouth or nose or eyes or like that, right? So then the infection occurs. When the infection occurs, at least in the mucosal surfaces, that is the wet surfaces of our body, there are, so if let's say this is the mouth, so let's say this is the mouth. When the infection occurs here, we have lots of glandular lymphoid tissues here, right? Mucosa associated lymphoid tissue or MALT. And when we go into the GIT, then we have GALT, GIT associated lymphatic tissue or gut associated lymphatic tissue. MALT and GALT are present. So when the infection occurs, a bunch of memory cells, T memory cell, B memory cells, they live here in the area of infection. Some of them will go to the local lymph nodes and live there. That is why the lymph nodes which get swollen sometimes with the infection nowadays, very common with SARS-CoV. So they live there as well. 2. Third, some of them would start circulating in the blood and tissues. 3. 4, some of them would end up in the bone marrow as well. Those that end up in the bone marrow will live there for decades. and offer protection. And we had done a study, we had done a discussion of SARS-CoV-2 study, which showed that after SARS-CoV-2, memory B cells ended up in the bone marrow and lived there, and the author suspected that they would be there 10, 20 years later. Same will be the case for T cells. The point with this are two or three. One is there is cross reactivity. So somebody who had previous infection will have protection now. That means somebody who has infection with one variant will have protection from the other variant as well. And although Omicron doesn't provide backward protection, but forward protections would continue to happen. That is one. These are coronaviruses. Secondly, there are cross protections. Somebody who gets a common cold with human coronavirus gets protection from SARS-CoV-2 or helps with the SARS-CoV-2 severity reduction. And I did that study as well. I'm not just speaking out of the uh, thin air. Third, the protection is longer lasting. So if it is not 17, 18 years, because we cannot see that far in the future, there is one conjecture I just showed you, months to 5 years. And if you look at the previous cousins, 10 years, 17 years later, the memory cells are working. So this is the talk. Um, Rima says that doc in Israel reports a key symptom is thick mucus, and patients coughing so hard from it, they have rib pain. Congestion seems to last forever. And that is very interesting because I also still have sinusitis and congestion, which is kind of reducing. I don't have any other problems, but I still continue to have that. So, yes, it seems like the newer symptoms, even new symptoms of Omicron, are not just a sore throat and nasal congestion and runny nose. They're also, number one, this thick mucus production afterwards, so sinusitis, and local inflammatory reactions, which, remember, at one point I had said, imagine local cytokine storm, although not a cytokine storm, but local immune systems dysregulation. Then joint pains, especially knee joint pain, and the back aches and the leg pains. These are very common as well. So cool. This is the discussion. I hope it makes sense. Let me see if there are any questions. We will skip the chit chat today. I have a little meeting after this that I need to attend. How do we know we had human coronavirus common cold? Any test? Thank you, sir. Not really. We don't have those tests. Just seeing if there are any. Jason says, "Are your lymph nodes even swole, bro?" So yes, actually, during my own COVID, one night I had my own lymph node on this side was swollen hard. So I don't know, bro, if your lymph nodes don't swell, but they do swell as well. Um, Jason, no, no, don't plan to get it. It's gonna be, just please don't. All right, so Dan says it is going to be 5 to 10 years. Of course, we can't even say for tomorrow or afterwards, but we can look at its cousins and see what their behaviors are. And it is very interesting to see 17 years later, 18 years later, they are providing protection. Samantha says, what do you think about the microclots? People are getting better from COVID. That is one reason, but there are many other pathological reasons as well. So Holly says, did you have any ear issues with Omicron? Yes. So I still have tinnitus, but really almost gone. So tinnitus and congestion, and there are folks here who said clogging, the feeling of the fullness in the ear, that has been very common as well. Paul Burks is glad they are catching up with Dr. Bean has been teaching. So I have been teaching mechanisms. I was listening to a couple of other presenters over this weekend, uh, and they were just continuing to say that the only way to understand is the RCTs. And I was thinking, yeah, sure, that is a 1 hour and a half long chit chat with you guys have, and you continue to say RCT, and you forget that we all learned mechanisms as well, and mechanisms have a value. For example, if I get infection somewhere, or if I get a wound somewhere, you don't have to go do an RCT to see how would this wound heal. We know the mechanism of healing, we know the process. So there are certain things that are just in the process. I've been looking at these processes and presenting the processes. It's just so strange that some of the doctors just want to have the RCTs for everything. Ebony, thank you very much. Grace says, sorry, late. Is blood clotting the same with Omicron as Delta? So, Omicron is generally, at least so far from the reports, it is milder. If that is the case, then everything will be milder. Again, we don't have the actual data yet to show. Lisa says, which nasal spray? So, the nasal spray that really helped me was the antihistamine. The steroid nasal sprays can be useful as well, but they would suppress the local reactions or local immune system, and that may be useful, but that could continue on with the microbe replication if there are this pathogen or other. So that immunosuppression suppressing effect may not be very much needed. So antihistamine. SNC says, I've heard that low testosterone and high testosterone can increase chances of COVID infection. Testosterone. So SNC, I'll have to look at the study for why are they saying that. So, what do you think of the study showing brain microglia causing inflammatory problems attacking myelin for 7 weeks of infection and some lingering cause? Yes, so John Snyder has actually been sharing a lot of studies that show brain damage or the brain tissue inflammation and damage. So I'm going to start talking about it, Denise. It's a reality as well. So Elijah says, does data support a notion that vaccinated or vaccinated individuals? Are you saying unvaccinated or vaccinated experience Omicron in the similar manner? We saw that they have a slight difference. Remember that California study? I did that a few days ago. You can just look at that. There still is a higher chance for infection and severity for unvaccinated, but the overall situation is actually much more reduced compared to Delta. So, Dr. Iron Mom, once on Odyssey, where do I find the banned Dr. Bean videos that I missed? So, if you go to Odyssey and look for Dr. Bean channel, you can see it. And over there, the banned videos would be, for example, ivermectin or hydroxy or Dr. Corey's talks. So Anne says, is tinnitus from COVID vaccine likely to disappear if it's due to neuroinflammation? Is it temporary? How does it differ from COVID infection? So look, I got tinnitus much more milder, but it is not gone yet. There are many patients who have tinnitus gone. We have Sean whose tinnitus has not gone. So I think it is varying among people to people. Jim says, have you seen the vitamin K2 study? No, but I was going to actually talk about vitamin K2 tomorrow. So I'll look into that. Rima says, please let's look at Israel. Absolutely. So tomorrow, I think we'll look at Israel tomorrow or day after, UK and Israel and their uh, data as well, especially in context of vaccines and their result. Jody says, this study may explain why some of us New Yorkers who were in Manhattan for SARS-CoV-1 still have not had a positive test. Who really knows? But it's possible. I still have my mask from back then. Yep, possible. At least it shows 17 years later there is cross reactivity. Uh, and is the mechanism different? They could be different or they could be the same. So tinnitus has so many mechanisms. At the end of the day, the hair cells could be damaged. That is one. Number two, the nerve that is actually connecting with the hair cell could be irritated or demyelinated and irritated or inflamed. And number three, the hearing area. uh, I'm patting here. This is the occipital visual. The hearing area of the brain could start becoming dysregulated. It might actually think that tinnitus is normal and just keep creating that perception. So there are so many reasons for tinnitus to occur that in various people, various mechanisms might get triggered. But all of them seem to be triggered either by inflammation or by ACE2 or by reduced blood supply to the inner ear that then causes hair cell damage or temporary damage. Cool. So let's. Ebony says, I have so many questions and don't know where to start. Hang around, we'll keep talking about various questions. So for today, I am going to beg leave from the chit chat. I have another meeting that my family is waiting. We just have a dinner together. So please like, subscribe, and share. And if you would like to support this work, there are links in the description. You can buy me a coffee, or you can be a patron, or you can use PayPal. Thank you very much, and we'll continue our discussion tomorrow.